Welcome, everyone. I am Lucia Corral Peña, a Senior Program Officer at Blue Shield of California Foundation. I'm really thrilled to welcome you to today's webinar called Breaking the Cycle, Addressing and Preventing Intimate Partner Violence through State Medicaid Policy. In partnership with Mathematica, today we will review recommendations for California. Before we begin, I'd like to introduce Tanya Marguerite from the Center for Collaborative Planning to go over a few housekeeping items for today's session. Tanya?
Great. Thank you, Lucia. Today's webinar will be hosted both in English and Spanish. The interpretation feature will not work through the dial-in number. So if you are on your computer and haven't done so already, you need to choose Join with Computer Audio. And if you are on your phone or tablet, you'll need to choose Call in using Internet Audio. Everyone participating in the webinar needs to select their preferred language. So if you're on your computer, you'll see a globe icon at the bottom of your screen. Click the icon to make your selection. If you are on a tablet or phone, click the three dots, then More, then Language Interpretation. Select your preferred language and don't forget to press Done. During the webinar, please use the Q&A feature to direct any questions to the panelists. And if you have any questions or need any technical assistance, please send a direct message to me or to my colleague Ha Tank in the chat. All right, back to you, Lucia.
Thank you, Tanya. We really definitely want folks to feel included in today's conversation. We have a lot to cover in 1 hour, so I want to just give you a brief outline of what we're going to be covering today. So after a brief overview by Amanda Lechner from Mathematica, who will summarize the approach that they took to do this inquiry and what brought us here today, we will then hear recommendations for state Medicaid policies from her colleague, Tony Abrams-Weintraub. Tony will be followed by perspectives from two of our national domestic violence field leaders, Lisa James from Futures Without Violence, and Christina Colon from the California Partnership to End Domestic Violence. Throughout today's session and at the end of our time together, we will be asking for your input and feedback. We look forward to creating a dialogue later during our Q&A session that will close out the hour. To get things started, I'm really thrilled to introduce our President and CEO of Blue Shield of California Foundation, Debbie Chang.
Thank you, Lucia. I'm excited to be here today as we explore how Medi-Cal can help break the cycle of domestic violence. People haven't looked deeply at Medi-Cal with respect to domestic violence, but there's huge potential and for impact. Medi-Cal serves nearly 14 million Californians with low incomes who are at greater risk of domestic violence. So you'll hear about these exciting possibilities today, but first, I would like to share the foundation's work and our approach, and how we're achieving impact, and why we're investing in this work on Medicaid with Mathematica. For nearly 2 decades, Blue Shield of California Foundation has been the state's largest private funder of efforts to end domestic violence. We've learned that to break the cycle of domestic violence, we have to stop it from occurring in the first place. And that requires addressing its root causes, such as gender, economic, and racial inequities. Preventing domestic violence is at the center of our mission as a foundation. Our mission is to build lasting and equitable solutions to end domestic violence and help make California the healthiest state. We know that children who witness domestic violence are more likely to experience domestic violence as adults. That's why we support multi-generational and life course approaches. A multi-generational approach is work that includes working with the child, the parent, and caregiver, such as a grandparent, all at the same time. When we use the term life course approach, we're referring to looking at the life course of a person and identifying those critical points where there are opportunities to disrupt the cycle of domestic violence. So how are we achieving impact, and why Medicaid? At the foundation, we want to have large-scale impact. And so we focus on policy and systems change. By systems change, I'm referring to the public and private institutions that serve communities impacted by domestic violence and health inequities. We believe that by systems change, we can reach the greatest number of people as quickly as possible with high impact changes that will improve their lives. Medicaid is one of these systems. As a former Medicaid director, I recognize that Medicaid can and should play a role in addressing early along the life course these issues by providing medical care, as well as connecting and helping to connect and identify those who are at risk of domestic violence or survivors with needed services, such as transportation and housing, and other services, such as counseling and education. So let me just say a little bit more about Medicaid and why Mathematica. Nearly 2 out of 3 Californians are affected by domestic violence, either directly or indirectly through a family member or a friend. And that's likely to be an underestimate because many people don't report cases of domestic violence. Domestic violence occurs in all communities, but we bet it can cause greater harm among the Medi-Cal population, who generally have lower incomes. It's simply harder to leave a violent situation when resources such that you need for transportation and housing are limited. Medicaid is a lifeline and a raft, in a sense, for communities with low incomes, especially communities of color. When survivors and those at risk have health care and they're connected to needed services, they have what they need to heal and prevent domestic violence in future generations. So you can see that Medi-Cal is well positioned to play a key role in preventing domestic violence, as well as advancing opportunities to promote health equity. The foundation partnered with Mathematica to identify approaches that leverage Medi-Cal's current authority to interrupt the cycle of domestic violence and reduce the likelihood of children growing up and experiencing domestic violence. Mathematica is a nationally recognized organization focused on the intersection of data, methods, policies, and practices. And they have an office here in Oakland. So now I'd like to introduce our two health policy researchers, Amanda Lechner and Tony Abrams Weintraub from Mathematica, and they'll continue this conversation. So take it away, Amanda.
All right, thank you so much, Debbie, and welcome everyone. I'm Amanda Lechner, the project director from the Mathematica team, and along with my colleagues, I'm really excited to be here today to give an overview of our project to help address and prevent domestic violence through Medicaid policy. We want to send a big thank you to the Blue Shield of California Foundation for providing the funding to carry out this timely and important work. Before I give you an overview of our project, we'd really like to get a better sense of who's joining us in the audience today. So if you will, please take a moment to answer the poll question that should have just popped up on your screen. So the question is, which category best describes the organization you work for? And I will give everyone a few seconds to answer the question, and we'll see who's with us in the audience. It looks like some people aren't able to see the question. I will see if this will work if we give it one more try. Some people are not seeing it, but we can go ahead and move along and maybe see if we can get this to work in a few minutes. So if you don't mind advancing to the next slide. Um, Here we are. Okay, thank you. So I'd like to just give us an overview of the goal and context for our project. And I just want to note one detail that for the purposes of our project, we're using a more specific term, intimate partner violence, or IPV, rather than domestic violence. So you'll hear us say IPV throughout the presentation. And as Debbie mentioned, there's really tremendous opportunity in California to play for Medi-Cal to play a role in preventing and addressing intimate partner violence. And there are many recent and upcoming policy developments in particular that offer new opportunities for Medi-Cal in this space. And so for the sake of time, I will just summarize some of these policy developments briefly as context to kind of set the stage for our project and what we've been working on. So we started the project back in April, and we really spent the first few weeks developing and seeking input on recommendations related to the CalAIM proposal, with the goal of helping to provide some recommendations during the state's open comment period back in the spring. And for anyone in the audience who might not be as familiar with CalAIM, just very briefly, it's a delivery system program and payment reform initiative that seeks to improve care for Medi-Cal beneficiaries with complex needs. And some of the changes to Medi-Cal included in the CalAIM proposal were enacted this summer. And another important piece of context is the Medi-Cal managed care reprocurement process, which is coming up. So over the summer, we began thinking more about ways that Medi-Cal managed care plans, along with the state Medicaid agency, the Department of Healthcare Services, can play a role in providing services to those at risk of IPV and services for survivors. We also reflected on developments coming out of the governor's office and other recent Medi-Cal policy changes, including increased funding and coverage of certain behavioral health services, family therapy, and dyadic services in Medi-Cal are two of those really important changes. And then also coverage of community health workers as Medi-Cal providers, just to name a few of the many recent and relevant policy developments happening here in California. Next slide, please. And just to give an overview of how we approached the project, at the beginning, we began by engaging partners from Futures Without Violence and the California Partnership to End Domestic Violence, who are here with us today, and we asked them to weigh in at various points in our project, leveraging their tremendous experience and expertise. We then conducted a series of interviews with approximately 20 stakeholders, including Medi-Cal experts, managed care plans, Medicaid staff in other states, state and local advocacy organizations, and IPV advocates and service providers. We then took all of that stakeholder input we gathered and began developing our recommendations, and we put out a couple of policy briefs with those recommendations. And then we collected further input from survivors and other experts. We shared those drafts, including with individuals who have lived experience, who are survivors, who also work now as service providers and advocates for other survivors. And then we conducted a focus group with survivors of IPV, whose input we're incorporating now into a report that is in progress and that should be finished in January or February. In approaching our work, we sought to center the needs of survivors by employing a life course framework, which Debbie talked a little bit about earlier. And just to say a bit more about that concept for anyone unfamiliar with it, it really considers the context, experiences, and individual factors across the individual's lifespan that influence the likelihood of a person engaging in IPV. And that perspective is critical because it allows policies, programs, professionals to intervene in the right moments in these critical periods in individuals' lives, and in doing so to address the factors that are the root causes of IPV, including poverty, racism, harmful gender norms, among many other factors. We also sought to conduct our project through a trauma-informed lens. And for anyone unfamiliar with trauma-informed care, it's a strengths-based approach to healing that recognizes the pervasiveness of trauma, the influence of trauma on health, and also aims to promote healing, empower survivors, and avoid re-traumatizing them. And the last thing I'll say about our approach is that it's rooted in the idea that trauma-informed and survivor-centered approaches must promote the dignity and autonomy of survivors by really providing the comprehensive services and supports that promote independence and well-being, offer choice to survivors, and help foster resilience. So with that, I will turn it over to my colleague, Tony, who will walk you through our policy recommendations.
Great, thank you so much, Amanda. And good afternoon, everyone. I'll start by sharing a very high-level summary of the recommendations and then spend some time walking through the specific strategies that we suggest for implementing each one. So next slide. We developed 4 recommendations. I'll just read through these 4 and then we'll dive right in. So promote universal IPV education, assessment, and response. Address health and social support needs of IPV survivors and those at risk. Expand access to comprehensive behavioral health services for survivors and those at risk. And support privacy and confidentiality needs of survivors and those at risk. Next slide, please. Thank you. Our first overarching recommendation is to promote universal IPV education, assessment, and response in healthcare settings. So on the left side of the slide, in the darker blue boxes, you'll see the stakeholder groups that have a role in implementing the strategies listed on the right. California's Department of Healthcare Services, or DHCS, you'll see on the slide, is the agency that runs Medi-Cal, and managed care plans, or MCPs, and healthcare providers are the stakeholders that can implement this set of strategies. The first strategy, train healthcare providers on the prevalence of IPV risk factors and related health impacts, is critical because many providers lack knowledge and training to effectively identify IPV risks and respond to any disclosures, or they might feel uncomfortable doing so. Training is essential, and to do this the right way, they need to partner with DV agencies and survivors that have the expertise. Helping providers understand the pervasive nature and the negative health outcomes associated with IPV and its relationship with other social needs will lay the groundwork for uptake of the next few strategies we recommend, namely universal education, assessment, and response. So the next 2 strategies are related: promoting universal IPV education in healthcare settings and combining IPV screening approaches with universal education. And universal education is an evidence-based approach in which providers speak with all patients about elements of healthy versus unhealthy relationships and the health effects of violence. Through universal education programs, providers also share resources with patients, such as crisis hotline numbers, that they can use for themselves at any point or for others in their lives that they care about. So in Futures Without Violence developed a model that my colleague just dropped in the chat for universal education. It's called CUES. And because disclosure rates for IPV are very low, systematically implementing universal education with all patients in healthcare settings increases the opportunities to support survivors and to promote prevention for those at risk, regardless of whether or not people choose to disclose. So while universal education is a more trauma-informed approach than a standard screening tool, Medicaid agencies could also recommend adoption of standardized validated screening tools, such as the HIT tool for IPV, and best practices for screening, such as speaking with patients in private without anyone else present and using culturally relevant language. These approaches are consistent with recommendations from the DV field to include safety measures in all social needs screening and with national efforts to screen for and address social needs, including safety of Medicare and Medicaid beneficiaries in healthcare settings, such as the Accountable Health Communities model. And the last strategy on this slide is to promote development of care plans that are trauma-informed. IPV survivors and those at risk might have complications, health risks, and safety concerns that providers should consider when developing patient care plans, particularly about reproductive and sexual health. And Medicaid agencies and MCPs should encourage development of trauma-informed care plans for those who disclose IPV that take partner interference into consideration. That is, when someone else controls access to healthcare, and that offer referrals to relevant services. And managed care plans should facilitate partnerships with IPV advocacy agencies to train providers on how to do this. Next slide, please. Next set of strategies relates to, we're still relating to survivors' social needs. So Medi-Cal and Medicaid, Medi-Cal and other state Medicaid agencies should encourage, incentivize, and require certain non-medical survivor-centered services and supports for survivors in lieu of or as value-added services. Particularly relevant services include transportation support, job placement services, childcare subsidies, financial services, legal services, home visiting, and parenting programs. So Medi-Cal should clarify and publicize that Medi-Cal can reimburse for non-medical IPV services in community-based settings and provide MCPs and healthcare providers with a list of examples of covered community-based settings and provider types. As with the other services I mentioned, this is really important to consult with IPV service providers to develop the guidance, particularly around appropriate payment methods for these in lieu of and value-added services. There's a good example in North Carolina. Their Healthy Opportunities pilots includes a per member per month payment system or per occurrence payments, depending on the specific service types. So MCP should consult with experts in this field to also identify common community resources and start to partner with those agencies to develop a network with clear referral pathways. And again, in terms of the payment policies, it's really important to consider privacy, and we'll talk about that again in a later recommendation. The next strategy is to promote housing stability among Medi-Cal enrollees experiencing, surviving, or at risk for IPV. IPV survivors are much more likely to experience housing instability, and in some cases, this may be why they stay in unsafe situations. So Medi-Cal can provide guidance to MCPs for how to provide and tailor housing services as in lieu of or value-added services to support survivors and those at risk. And these should include supportive services that are trauma-informed and survivor-driven with flexible financial assistance to enable survivors to meet their housing needs. An example of this is the DV Housing First programs in California, and there's one in Washington State as well. Moving to the next strategy, provide enhanced care management that is trauma-informed to IPV survivers and those at risk. An example of this is in Oregon, there's a coordinated care organization. It's their version of MCPs. And one of them uses a global payments it receives from Oregon Medicaid to finance care coordination provided by contracted agencies. The last strategy on this slide is to cover prevention, education, and services that are trauma-informed that community health workers and promotores provide to IPV survivors. So CHWs and promotores are typically trusted community members with particularly strong understanding of the communities they serve. And therefore, they're well positioned to build trust with survivors, identify any health and social needs, and help survivors navigate those services. So many MCPs, particularly those participating in California's Health Homes program and whole person care pilots, may already employ or contract with CHWs and promotores to provide outreach, navigation, and peer support services for beneficiaries with complex needs. So state Medicaid agencies can provide contracting guidance to MCPs, like the resource that California Healthcare Foundation released that provides guidance about this. Next slide, please. Continuing with strategies that address social needs, Medicaid agencies and MCPs should cover home visiting services and include universal IPV education and resources in all types of home visits. Home visiting programs as a two-generation approach can disrupt the intergenerational cycle of violence by equipping parents and children with tools that promote positive parenting and child development. Currently, coverage of home visiting in California is inconsistent, and Medi-Cal should fully cover home visits and make them uniformly available. I've mentioned this next strategy, building partnerships with community-based organizations, briefly already, and it's also included, our brief that you'll see also includes several examples of these partnerships. The last strategy on this slide recommends that Medicaid agencies consider supporting state-level interagency collaboration to address and prevent IPV, to connect the multiple agencies that address different needs of survivors. I'm going to take a minute now. We have 2 more recommendations to share, but I'll pause at this point to see if we can get some feedback from all of you. So we're going to try to launch another poll on your screen. And this question is, from your perspective, which are the 3 most urgent strategies that would help meet the non-medical needs of survivors and those at risk? There are quite a few, and they're all important, but it'd be helpful to get your perspectives on these priorities. I'll give you a moment to read the choices on your own, and please rank your top 3. Looks like we're still having trouble with the poll. Can someone message me and let me know if anybody can see the poll? No poll. Okay, moving on. Sorry about that. I'm not sure what's going on with those. Next slide, please. Thank you. So the next recommendation, these next set of strategies focus on critical behavioral health services. We recommend that Medi-Cal and other state Medicaid agencies explicitly include exposure to IPV as a risk factor that qualifies children and youth to receive specialty mental health services. This important mechanism intervenes at critical junctures in development to disrupt the intergenerational cycle of IPV. The next strategies here are for Medicaid agencies and MCPs to enhance the definition of dyadic behavioral health visits and encourage the use of these and parent-child therapy services. Dyadic care is a model that integrates physical and behavioral health screening and services for children, youth, and their families, and promotes positive parenting approaches. Dyadic models typically embed child development specialists with pediatric primary care teams to promote screening and provide referrals to behavioral health and social support services. And research shows that these services are associated with violence prevention. Medi-Cal and other state Medicaid agencies and MCPs should specifically incorporate the needs of survivors when defining dyadic services and specifically include IPV-related services like immediate safety planning, behavioral health care, and appropriate social supports. Some local providers in California already use several of these evidence-based models of family therapy and dyadic care, such as Healthy Steps, parent-child interaction treatment, and child-parent psychotherapy. To encourage the use of family therapy and dyadic services, Medicaid agencies and MCPs should train providers, encourage them to render these services, and make patients aware of these new covered services. Next slide, please. This last recommendation is about supporting the privacy and confidentiality needs of survivors and those at risk. It's critical for safety. Survivors can be at increased risk for harm if the person causing the harm finds out that the survivor disclosed IPV or about any services they may have received, such as behavioral health care. Therefore, it's important for agencies to take special measures when documenting and billing for services. And some specific strategies that state Medicaid agencies and MCPs should adopt include developing protocols to protect privacy and confidentialities, and then educate healthcare providers and staff to implement them. And protecting the safety and privacy of survivors and payment strategies developed specifically for IPV. MCPs should support survivors' use of, trust in, the healthcare system by partnering with IPV service organizations and survivors to train providers on key protections. For example, sharing healthcare data should require robust informed patient consent about any reporting requirements. Patients should have control over how their data are shared and with whom, and who has access to the data and when the data are shared need to be transparent. And because the risk is so high of harm to survivors, there should be enforceable penalties for privacy violations. So state Medicaid agencies and MCP should seek recommendations from IPV experts to develop innovative strategies to pay for IPV services without compromising safety. As one option, consider a model that sets a monthly flat fee to cover for services for a projected number of survivors, rather than tying payment to billing based specifically on individual services. As you'll hear in a bit, it's important to consider the capacity of CBOs to participate in billing protocols. Okay, so I just threw out a lot of information there. I'm going to pause and pass this to one of our partners to share perspectives on their recommendations, on these recommendations. So first, I'd like to welcome Lisa James, the Director of Health at Futures Without Violence. Lisa.
Thank you so much. And thank you for those fantastic recommendations. We go to the next slide, please. Next slide. Thank you. I just wanted, I think in listening to everything that was shared, I guess I wanted to just first of all lift up that we do have information and data that the interventions described really make a difference for survivors. And so there was a number of different interventions discussed. One of them was cues, which was put into the chat. And I just want to lift up that we know when implementing cues, we have an opportunity to promote prevention because we're offering resources about healthy and unhealthy relationships, regardless of whether or not somebody chooses or feels comfortable disclosing that they may or may not have been experiencing domestic violence. And when we do that, we've seen an improved awareness about what healthy and unhealthy relationships are. We've seen changes in the knowledge, attitudes, and behaviors to promote safety. And we've seen a real uptick in offering peer-to-peer education and prevention messaging as we offer these resources to everyone for them to share with friends and family members. And when we think about intervention, we've also seen that even though in this particular model, we're offering a universal education approach, which isn't reliant on disclosure, when introduced in this way, we've seen increases in disclosure of intimate partner violence and help seeking. And we've seen a decrease in abuse and coercion victimization. And just a word about the decrease in coercive victimization. I wanted to lift up that when we really think about it and this model of moving away from simply a screen and refer model, but we start to think about how can we work with the patient to create a care plan that really understands the realities of what that person's going through. So if you're working with somebody whose partner is directly interfering, say with their efforts to become sober or is directly sabotaging their birth control, then you as a healthcare provider's efforts to promote sobriety or to promote or decrease unplanned pregnancy are going to be ineffective. So that's why it's so critical to also think about what's happening and counsel and partner with the patient at hand to think about a trauma-informed care planning prior to making a referral. And I think it's because of these approaches that we're seeing those decreases in abuse, victimization, and coercion. Next slide, please. Then in terms of thinking and reflecting on the recommendations that were made, I'm excited about the opportunity here. I think there is a precedent. There are other states, as has been mentioned, are leveraging Medicaid to respond to intimate partner violence. North Carolina's Healthy Opportunities pilot was mentioned. So we have folks to turn to and lessons to learn from them. But I think that California can really be a leader here with the focus that's being presented here today on prevention and really looking at those multi-generational and life course strategies to address prevention through home visiting and other programming, and then also even in the clinical setting as described above. I do think that there is a lot going on as it relates to responses to healthcare changes overall, as Tony and Amanda mentioned, and to responding to intimate partner violence. So I really think it's critical to promote some coordination between departments of public health and Department of Healthcare Services so that we can align our efforts and make sure that they're coordinated and as survivor-centered as possible. Tony, you mentioned the privacy strategies, and I just want to underscore that, and probably Krista will as well, because that's so critical to the safety of survivors as we do this work. And we don't want to implement programs designed to help survivors and their families and prevent violence and cause more harm in doing so. So absolutely critical to think about privacy considerations. I think we need to adopt some standards either at the state level or plan level around those privacy considerations, because it is much more than just privacy for survivors of violence. It's also a safety issue as well. So when I'm thinking about that, I'm thinking about the implications for how things get documented in the electronic health records and where that documentation goes as it relates to explanation of benefits and what have you. We've seen a real concern with the Cures Act and folks just particularly some of the platforms, the electronic health platforms, having a blanket opening up of those records so that patients have access to their health records, which in many cases is incredibly useful and has been a response to demand for access. But in the case of domestic violence survivors, you really want to make sure that they think that's going to be safe for them to have those records become public in case they're the person who's causing them harm might see that. So I'd like to argue for us to not automatically flip the switch, as it were, when it comes to sharing any kind of documentation on domestic violence, but communicate with the survivors on that front. And similarly, we're seeing a lot of an uptick in use of the social referral platforms, and there's absolutely critical need to create some standardizations and recommendations around privacy principles for what gets shared, and also consent principles as they relate to domestic violence. So we have some resources on those fronts, which I can put into the chat in just a moment. I'm good at talking and chatting at the same time. And then lastly, just want to underscore that some of the comments made that domestic violence programs and advocates are absolutely critical members of the care team and should be treated as such, so that we can create some meaningful responses and meaningful partnerships between health systems and advocacy programs. And so definitely invite all of you who might be considering doing this work to partner with their domestic violence programs, to think about creating memorandums of understanding and streamline referral processes, and think about the ways in which we can leverage Medi-Cal to make sure that domestic violence programs and advocates are considered part of the care team. And I know Krista will have a lot to say that as well. So I think I will turn it over to Christina Colon, who's the Public Policy Director for the California Partnership to End Domestic Violence. And for those of you who don't know about this fantastic organization, they represent over 1,000 advocates and programs throughout California. And Krista will be the perfect person to talk about the importance of these partnerships moving forward.
Thank you so much, Lisa, for that introduction and transition. I think you previewed well some of the pieces I want to touch on. Really to pick up where Lisa wrapped up, working with domestic violence programs can be an essential extension of the care that is provided in medical settings for survivors. Domestic violence programs are supporting survivors who are navigating mental health needs as well as physical health needs. And as has been said earlier, and really some of the nexus for today's conversation, we know that there's likely already overlap between Medi-Cal clients and domestic violence program clients. And for those of you who may not be too familiar already with what it is that your local domestic violence programs here in California and all across the 56 states and territories are doing, just a few examples of some of the services are up on the slides for you. These are programs that are answering hotlines 24/7 from survivors in crisis, helping them navigate immediate safety as well as long-term healing. They are providing a whole range of housing supports and services. Already lifted up was California's Domestic Violence Housing First program, which I could spend an entire hour talking about in and of itself. But they are really providing the whole range from emergency shelter to longer term transitional housing, advocacy with landlords to help survivors stay housed or become newly housed, helping to prevent homelessness and do rapid rehousing. which I think we all know that in trying to provide appropriate medical care to any individual, housing stability, a sense of safety can be really key components to their ability to have the physical and mental healing that they need. Programs are also doing quite a bit of legal assistance. This includes restraining orders, custody, divorce, supporting survivors as they navigate through the criminal system if there is a criminal case pending, working with them on immigration protections and relief, economic justice issues, housing, and really everything that you can imagine comes into play for survivors. Programs are also in their own organizations providing counseling, whether that's individual therapy or peer-to-peer counseling and group sessions, as well as addressing the needs of children and providing counseling and group sessions for children. These programs also, many of them are focused on language access and culturally specific services. So we're really proud to have so many organizations in our network here in California that are developed by and with and for culturally specific communities, and that are really grounded in the cultural healing and the cultural practices that those survivors need. And then, of course, these programs are helping survivors navigate through a whole range of complicated systems, whether that's CalWORKS and CalFresh, which are California's versions of TANF and SNAP, the child welfare system, our legal systems and courts, as I mentioned, but really every government system and bureaucracy that survivors need to navigate, our programs are there with them to help them through that process. And I think as you look at this, you can see why having that bridge between medical care and these types of advocacy programs can be really essential for comprehensive health and well-being of a survivor. Next slide. So some connections for you all. Just in case you aren't already connected with your state domestic violence coalition, your tribal coalition, or your local programs. I believe these slides will be shared, but I will also drop all these links in the chat for you. So some links here for you. The first is a link to all of the state and territory coalitions. We are lucky enough to have a counterpart organization in each of the 56 states and territories. And thank you, Julie. I saw in the chat, you put the link to where you can all access these resources. In many parts of the country, you'll also find tribal coalitions. And for those of you who do have a tribal coalition in your area, strongly encourage you to build a relationship with them, just as you would with your state and territory coalition. And then finally, thinking about our local level work, get to know your local community. We have on our website a list of all of the programs in the state, as well as a map that you can search and find where they are geographically. So again, I'll put that link in the chat, but it's a really helpful tool. Many of the other state and territory coalitions will similarly have a directory on their website of all of the local programs in their state. Next slide. Excuse me. So just some reflections on the recommendations, and I think these are things you've already heard, but I think these recommendations are really a powerful opportunity to build really meaningful connections, to incorporate this piece of survivor well-being with the resources and services they rely on, to truly and better connect their healthcare needs with the other services and needs that are essential. It's a way to help build new partnerships and to make all of our collective work stronger, to help meet those goals of supporting survivors through their healing journey. Some recommendations that I want to continue to emphasize, as Lisa indicated, is being really thoughtful about building agreements with domestic violence service providers that don't add new and tremendous burdens to them. Right. Keep in mind, these are organizations already grappling with their own grant requirements and funder structures that they need to meet. So be thoughtful when developing those partnerships, really build in conversation to avoid requiring new complicated databases, extensive documentation, or complex invoicing practices that may make a partnership feel unattainable for a domestic violence provider. And also just to come back again to this point around client confidentiality. This is an area that's so important to just continue to recognize that there are differing client confidentiality client confidentiality requirements for the different types of organizations. That the patient privacy requirements that medical providers operate under are different from those of domestic violence service providers. Domestic violence programs operate under this acronym soup I've given you of the Violence Against Women Act, the Family Violence Prevention and Services Act, and the Victims of Crime Act. And there are very specific restrictions they need to follow, specifically when it comes to client level information. And so again, this is where building a true and meaningful partnership, working closely with them to establish what works for both medical providers and for domestic violence service providers in terms of documentation, information sharing, and what's going to be appropriate. We have some basic resources on this that I can share, but it's worth some really in-depth conversations. Quite honestly, we've seen in other settings where this hasn't been built in from the very beginning, and where it's become then very challenging for domestic violence programs to appropriately engage. And we see this particularly as an ongoing challenge in the housing and homelessness space when it comes to homelessness data. So this is a lesson we've learned as a field over many years. And I'm really appreciative to Tony and Amanda and to Lisa for continuing to echo the importance of really thinking about and building privacy and confidentiality in from day one. So I think that is the short version of some reflections from myself. I think if we go to the next slide, we can go ahead and turn this over to Lucia to lead us through some discussion and Q&A.
Thank you, Krista, and thank you to all of our panelists. As I invite you to come back into the virtual room, I want to switch the focus from you all hearing from us to us hearing from you. So the first, and we'll have a Q&A with the panelists in just a minute. So I really encourage you to submit any questions. Before we get there though, we would like to ask you some questions about how you may be integrating policy efforts into your own work already with survivors or with healthcare patients and screening, et cetera. So our first question is, do you integrate policy efforts into your work to prevent domestic violence? And we are really hoping that the third time is the charm on this poll. So please, hopefully you can all see it, and please respond. Yes, thank you, Natalie. Thank you, Christy. Courtney, yes, okay, so please respond. Do you integrate policy efforts into your work to prevent domestic violence? I think I'm gonna need some help here because what I can't see is the results of the poll. There we go. All right. Great. Well, it looks like we have yes for some and no, not yet. So I hope that for those who are no, not yet, what you heard here from our amazing panelists is some inspiration to do that. And for those of you who are doing it, I hope that this also offers you some inspiration and new information to really keep the centered voice of, to center the voice of survivors, the experience of survivors, and support you in doing that in the policy efforts that you're engaged in. Our next policy question is about, I'm sorry, it's not a policy question. And our next question is, based on what you heard today, would you be able to explain that to a colleague? We're curious, this is a, Medi-Cal is a complex field. policy advocacy can be also, and we covered a lot today. So curious about whether you would be able to explain some of what you heard or all of what you heard with a colleague. All right. While we're waiting for that, to see the polling response, please get your questions in the chat box. All right, yes, okay. We have many of you who can explain what you heard today. And for those of you who are having a little trouble with explaining what you heard today, that's totally fine. It's a lot. So let's move on to what we hope is some exchange in the chat box and with our panelists. So for those of you who feel that what you heard is something you could communicate to others, help your colleagues out who are on this line who may need a little bit of help. You know, from what you heard today, what was resonant with you the most? Please put your thoughts in the chat box. Okay, it looks like we may have a shy group here. Well, while we're waiting for comments or additional questions from all of you, I'm going to ask a question of two of our panelists. I mean, I think Krista got us started here a little bit on how do you partner well with domestic violence providers? But one question I would ask Amanda, Lisa, and Krista again is what would help facilitate partnerships with domestic violence providers to further explore and plan for some of the recommendations that were presented today? And why don't we start with you, Amanda?
Sure, yeah, and this is a great question. And so one thing we heard a lot in speaking with stakeholders, with service providers in interviews and in sharing our recommendations with them is this need for kind of an ongoing conversation and input from them as policy making happens, you know, including them especially in thinking about how to develop payment methods and information sharing procedures from Medi-Cal, and you know, just getting their voice because it is complex and there are the special considerations, especially that Lisa talked about. So that is kind of the main theme we heard in doing this work.
Thank you, Amanda. Lisa, do you have something to add to that?
Sure. I'll just lift up that all the usual elements of a successful partnership are really important here when it relates to partnerships between healthcare and domestic violence advocacy programs. So clear understanding of what each other does. Krista laid out some of those, the elements of the programs and the services provided, and many people are not aware of the depth of services that are offered. So understanding each other's services provided, understanding the language from both healthcare and the advocacy community. I mean, we all use different acronyms and different languages, and we have different approaches, but very parallel in many ways. But we have to spend some time understanding each other's language. And then when you're thinking about creating meaningful partnerships with advocacy programs, I agree, Amanda, that you really want to start fresh and early if you're starting a program new, and so that you can have your local program be aware of what you're doing, understand the implications for survivors, and then talk very critically about some of those elements that you mentioned in terms of privacy, consent, and data sharing. I think those are the tricky issues that you just need to work through together so that you can reflect what Krista talked about in terms of the confidential services and their federal requirements to provide confidential services. So that's another piece you just really want to focus on. And Krista, you probably have more to add there.
No, I think both you and Amanda covered it. I think we hear at times about all the things we wish new partners wouldn't do, of, reaching out 2 weeks before a contract is due, and expecting to get quick buy-in and quick signature. Making that time to build a relationship that feels like a two-way street, right? And recognizing that they bring your partners bring as much value to the table as you do and should be considered equal partners. But I think both Amanda and Lisa really touched on all of the great and correct ways to build meaningful and hopefully long-lasting relationships and partnerships.
I'm
Thank
sorry,
you.
Lucy, I might add one other thing that I didn't think of,
Yeah.
which is also to not forget that, the opportunity for preventive services that the partnerships can really contribute to. So there are a whole host of multi-generational and life course responses and prevention efforts that are happening on both the healthcare and on the advocacy side. So we can really build off each other's efforts there to start to get at prevention and address root causes and break the cycle, as this session is called.
Mm-hmm. Thank you, you three. I think what I heard is process matters, relationships matter, and a prevention mindset matters, and partnerships can move all of that. I think we have time for one more question with very quick, with concise answers. So here's the question that we received is, there's interest in the role that survivors provided input into your thinking for the recommendations. So what was the most important or influential insight from conversations with survivors that influenced the recommendations? Amanda, I'm going to ask you to answer that question. And then Lisa, I know you've worked with survivors at this intersection. So would love any quick observations here.
Yes, and thank you for this question. So if I had to pick one thing, really the most important piece that stands out is the need to really understand what that security and confidentiality means to protect safety in all services offered to survivors. There's a lot of fear of further harm happening if someone finds out who is causing a survivor harm. There's a lot of fear around that, and also just the importance of having those safety procedures in place to protect security and confidentiality, but also of making that known to the survivor so that they're able, to speak up if they need support.
And Lisa?
Yes, I think we've heard time and time again from survivors that it's important not to push only for disclosure, and don't require disclosure. Disclosure shouldn't be the only way in which that you can get the services and supports that you need. So especially in a state like California where there's mandated reporting, it's absolutely critical, and survivors have let us know that being able to receive education and supports, regardless of whether or not they feel comfortable disclosing, is a critical component to success and to building trust and partnership between patients and providers.
Thank you, Lisa and Amanda. I think with the 1 minute I have left, I want to close this in one important way, two important ways. One is I want to encourage all of you to review the full findings at the link that was included in the chat. All of the materials can be found on the Blue Shield of California website. I want to also say something that Lisa mentioned, that California could really be a leader in this space. One of the reasons I totally 100% agree with Lisa, and Krista is evidence of this, is that we have a dynamic and innovative domestic violence field of leaders. They are women warriors for the most part who are doing some amazing work in advocating for clients. And at the same time, we also have a very dynamic healthcare environment where we have leaders who care about prevention, who care about their patients, and meeting and advancing prevention. So I think this is the right state to lead the country, as we often do on many issues. I want to thank all of our panelists for your comments. I want to thank Mathematica for your very clear presentation of the recommendations. Much more information to be found on our website. Krista, Lisa, Tony, Amanda, Debbie, thank you so much. And I really want to thank all of the team at California, at the Center for Collaborative Planning and at the Blue Shield of California Foundation, who made this webinar possible and did all the important back-end work to make this a powerful session. So, and if you asked a question that we didn't get to, we will definitely follow up. Thank you again for joining us.
Thank you.